I don't show again everywhere don't burst like. Na the video for clavicle be this. Number one, boom. Na this bone you go jack start dey feel like boss, like say na you be Elon Musk or something like that. You go hear people for class start dey discuss about medial, lateral, two third, one third. You go just choke. Okay, jokes apart, make we go into business. We are going to be looking at the introduction to the bone, the location, its features, parts, anatomical position, features and attachments, and clinical correlations. Now we can dive straight into introduction. Clavicle na S-shaped bone. When I say S-shape, I dey talk about elongated S wey dey drag like the one wey you dey see for your screen. The bone dey attached medially, that's at the center, to the sternum, and e dey attached laterally, that is at the side of the body, to the acromion process of scapula, as you dey see for your diagram. This bone na only im be the bone wey dey connect upper limb and trunk, that is and chest. This bone form the only bony attachment. Muscular ones dey o. Now make we take a look at the location of this bone. That is, make we just check how this bone dey placed in the body. Now this bone is placed horizontally despite being a long bone. Unlike other long bones that are all arranged vertically, this guy is placed horizontally, and it is at the anterior aspect of the body, at the junction of root of neck. Wetin that one mean be say e dey at the place where neck dey terminate, and e be the part wey dey connect the neck and the trunk. At that junction where clavicle dey, na im neck dey stop, trunk dey begin. Also, this bone dey subcutaneous, meaning that this bone dey directly under the skin. In other words, you can touch this bone at any portion along its length, indicating that it is palpable along its entire extent, where palpable means say e dey touchable. Even for the diagram sef, you go see say the bone dey very obviously looking. Just touch am, just try touch am as you dey watch this thing. You go see say at any point you fit touch the clavicle. Now make we take a look at the features alongside a few functions. We don already mention say this bone na the only long bone wey dey horizontal, and we don mention say e dey subcutaneous throughout its entire extent. Now, one interesting thing wey you suppose remember be say na this bone be the first bone wey go start dey ossify. In other words, na im go first start dey turn bone for the body, but this is also the last bone to complete that ossification. In fact, you go 2021 sef before the bone go complete im ossification. Now, regarding the functions of the clavicle functions are: first of all, it holds the upper limb to swing clearly away from the trunk. That one means say e dey keep the upper limb away from the trunk. In other words, e go dey easier for you to move your upper limb away from the trunk. For say clavicle no dey, e for dey hard. Now we get also the transmission of forces function. That means that the clavicle dey serve as medium through which force wey dey come through your upper limb go pass into your trunk. So this is a weight bearing structure in the human body. Next up, we go carry body enter the parts of the clavicle. I sure say na here some of una dey wait for. Now, the clavicle has three major parts: one shaft and two ends. That is, e get one central long portion as I dey indicate, and two ends. Two ends, that is, one at the medial side and one at the lateral side. So we get a lateral or acromial end, a medial or sternal end, and we can get the shaft in the middle. E just dey like many other long bones wey get two ends and a shaft in between. Most of them have upper and lower, except for clavicle. Why? Because clavicle dey horizontal, they dey vertical. So them they go get upper and lower end, but clavicle get medial and lateral end. This medial end, we dey call am sternal end because e dey articulate with sternum. E dey join with sternum for that place. We get lateral end being called the acromial end because e dey articulate with acromion for that side. Now let us take this part one by one. We will first of all look at the ends. The ends, we have the sternal end wey be the medial end. The end dey enlarged and quadrilateral, meaning say the end fat well and e con get like four sides. This end get small notch wey e dey use articulate with the sternum at the clavicular notch of manubrium sterni. Now this they call stuffus compactus. You go start to feel like the magnum opus because stuff done too much for your head. We have the lateral head that is flat from above downward. That means say the lateral head dey flat in front. E no pass like that. And this lateral head is attached to the acromion process of scapula. Acromion process is one of the processes of scapula. We go treat am. Next up, we get the shaft wey get two parts. These two parts na dem be wetin we dey call medial two-third and lateral one-third. So medial two-third is medial and lateral one-third is lateral, of course. So the medial two-third of the shaft now is bigger than the lateral one-third. Let us first take the medial two-third. This medial two-third that is bigger is having convexity dey face front. If I say convexity, I mean say e push go front. So like two-third of the shaft dey push go front. That is, if you say like you split the clavicle into three, two parts out of that three na im be medial two-third, and then the last part na im be lateral one-third. Now those two parts dey push go front. Na how we take dey identify medial two-third be that. Now the smaller lateral one-third dey push go back. That is what we call concavity. Now as e dey push go back, we have concavity in the lateral one-third, and then we have convexity in the medial two-third. So you get it? Medial two-third push to the front, lateral one-third push to the back. So medial convexity and lateral concavity. Now let us take a look at the anatomical position of the clavicle. How to place it in that position. To place the clavicle in anatomical position, you see that medial convexity, let it face front. That lateral concavity, let it face back when you are holding it. Also, make sure say the quadrilateral end e dey the medial side. The what? The flattened end e dey the lateral side. Also, below the clavicle in the shaft, you go see one small groove or small hole or marking wey go just dey that place. Na that thing you go take as your marking for the inferior surface of the clavicle. That is the part wey go dey face down. That groove, the name na subclavian groove. Now make we look at the features and attachment of the clavicle. Let's start from the ends. We get the lateral and or acromial end. This lateral or acromial end dey attach himself to acromial process of scapula to form acromioclavicular joint. This is the joint between the clavicle and the scapula. The margin of this end dey also give attachment to the fibrous capsule of the joint. That is the capsule wey dey surround the joint. Yes, e dey also give attachment to that. Now we get the medial or sternal end wey dey saddle shaped, like saddle for horse now. E dey saddle shaped, and e get articulation with the clavicular notch of manubrium sterni, as we don call am before. Now this clavicular notch of manubrium sterni together with this sternal end, which is the medial end, together form what we know as sternoclavicular joint. Now this end go also give attachment to the fibrous capsule of this joint and some other ligaments like interclavicular ligaments and the articular disc of the joint. Now for the shaft, we get the lateral one-third and the medial two-third. Let's start with the lateral one-third. The lateral one-third has two surfaces and two borders. Surfaces, that's the flat part where are the point right now, and the borders are the sharp edges. Now two surfaces and two borders. We have the superior and inferior surfaces, and we also have the anterior and the posterior border. The superior surface dey completely subcutaneous except for the part where deltoid and trapezius insert on top the clavicle. So apart from these regions, it's completely subcutaneous. That is, it is directly under the skin. Now the inferior surface is presenting some things. These two things are the conoid tubercle and the trapezoid ridge. The conoid tubercle is just like a small kind of elevation wey just dey at this inferior surface of the lateral one-third, and it is near the posterior border, meaning say e close near back. Now we also have the trapezoid ridge wey dey extend from this conoid tubercle. They extend medially and anteriorly, that is towards the center and to the front. So this is the coracoclavicular ligament related to the inferior surface of this clavicle. You see that it is attaching itself there, both the conoid and trapezoid parts, those two that are dark blue. Then we also have the anterior and posterior borders, where the anterior border, the deltoid muscle is inserting along the anterior border, and the trapezius muscle is inserting along the posterior border. We can't get the medial two-third, we get four surfaces rather than the normal two surfaces and two borders we lateral get. We get four surfaces. These four surfaces give them a kind of cylindrical or quadrilateral shape. Now we have the four surfaces being anterior, posterior, superior and inferior. Now for the anterior surface, it is convex forward. Wetin dat one mean be say e bend go front. Dis surface dey give attachment to the clavicular head of pectoralis major, that is the head of pectoralis major wey dey attached to the clavicle. Next we come get the posterior surface. Dis posterior surface we go talk say e dey concave backward because if you look am from back e bend go inside, so for front e bend go front which is convex forward, so from back it is concave backward because e bend go inside. Now near the medial end on dis posterior surface, dis muscle dey attached, stenohyoid is attached near dat end. Then on the lateral part we come get this lateral part forming a boundary for the cervico-axillary canal. Wetin I talk? Cervico-axillary canal, which is like the head, that is the upper part of axilla. E just dey like the part wey dey link to axilla directly. So this lateral part of the medial two-third of clavicle dey form the anterior marking of the cervico-axillary canal, which is the opening part of the axilla, the part wey dey use enter the axilla from neck. So it is related to a lot of content of the axilla. Next up we get the superior surface. This superior surface now e give attachment to the clavicular head of sternocleidomastoid from its medial half, meaning say the medial half of the medial two-third dey give attachment to clavicular head of sternocleidomastoid. So sternocleidomastoid muscle go come from up, insert on the superior surface. Lastly we get the inferior surface where we get the subclavian groove on the lateral side. So on the lateral side of the inferior surface, that's the lateral half of the inferior surface, we get subclavian groove. And this subclavian groove now, they get different things wey dey attach there, like the costoclavicular ligament, the clavipectoral fascia, the nutrient foramen, but most importantly the subclavian muscle wey dey go directly into the groove to attach itself. The nutrient foramen na just hole through which artery dey carry blood enter the bone, even bone gas chop na. Right now the images wey you dey see for your screen na dem be the images of the different parts of the clavicle and wetin dey attached to them at those parts. So pay attention to the structures because right now I'm sure there are a lot of things that are confusing to you as you are a beginner in anatomy. So try and look at those muscles and just look at how they are related to the clavicle. Next up we go clinical correlations, the most important of which being the fracture of clavicle. So fracture of clavicle is a fracture that is kind of common clinically, and one of the major leading causes of this fracture is falling on an outstretched hand, like hand wey dey stretched, like make person just fall down on top im shoulder, or make the fall just dey hit am for wrong place. So the reason why this fracture dey easily happen during this type of occurrence na this. Look at the clavicle now, that L shape of clavicle e dey facilitate something at the point where medial two-third and lateral one-third come together. There is a weakness in that spot, that is the spot of maximum curvature on the clavicle. Now this curvature now e dey make that area weak. Now so where forces are being transmitted to the upper limb to the trunk, and this time around the force is so powerful and just come at once, it is possible for the force to snap the clavicle at that place. Also direct blow to the clavicle fit just fracture the bone at this location easily. Now the three major things wey dey cause this type of fracture at this point is that this place is the weakest site of the clavicle. At this point the curvatures dey meet, and then there is also transmission of forces. So these are the three important things that cause the clavicle to be easily fractured at this position. Also next we have other clinical correlations like cleidocranial dysostosis and clavicular dysostosis. However, before that, let me tell you a small story. When clavicle begin dey develop, e get two ossification center, one at each end. We have the medial and the lateral. Cool. So these two centers wey don appear now, they suppose dey grow towards each other make the bone complete, but that's not the case always. Sometimes these two centers they might not meet completely, meaning say the bone fit no completely ossify, the center e fit get one part wey dey deficient. Now this is what we call clavicular dysostosis, meaning that the clavicle has two separate parts. That means that the two primary centers dey no meet, so clavicle remain separate. So we have clavicular dysostosis. Then we come get the other one wey be cleidocranial dysostosis. Cleidocranial dysostosis occurs due to partial or complete absence of clavicle. That is when there is defective formation of skull bone. That one you go understand am well when you read embryology to some certain extent, so no bother too much about it right now. So we have mentioned three clinical correlations: fractures, clavicular dysostosis and cleidocranial dysostosis. Thank you very much for watching o. Remember to like and subscribe before you leave the channel abeg. Like o, like o, like o.